Hi. So I'm going to discuss the nice guidelines for managing acute asthma in adults in 2019. And I thought I'd make a video about it in a flow chart because I couldn't find a video online and I was just having trouble ingesting all that information. So, nice guidelines for 2019 states that asthma can be classified as a moderately severe asthma, a severe acute asthma, a life threatening asthma, or a near fatal asthma. So, we got to know how to classify a patient as having uh, any of these categories of asthma, like which category to classify the patient in. So, a patient who has moderately severe asthma will present to you with symptoms that are progressively increasing. And for all patients who present with asthma, acute breathlessness, you're going to do a peak expiratory flow rate. So, in moderately severe asthma, your patient will typically have a peak expiratory flow rate of 50 to 75% of the best peak expiratory flow rate. I'm just going to go ahead and call it PEFR. Best previously recorded PEFR or the predicted PEFR for that sex, age, weight, etc. Also, this patient will have no signs or symptoms of severe acute asthma. So then we got to know which patient can be categorized as having severe acute asthma. These are patients who have a peak expiratory flow rate of 33 to 50%, a respiratory rate greater than or equal to 25 per minute. They'll also be tachycardic with a heart rate greater than 110 per minute, and they'll usually be unable to complete their sentences because of their breathlessness. Patients can be classified as having life threatening asthma if their peak expiratory flow rate is less than 33%. So, a patient with a peak expiratory flow rate of less than 33%, a patient with hypoxia, that is a saturation of less than 92%, and a PaO2 of less than 8 kilopascals. So at this point, you've done an ABG. So PaO2, any patient that has a saturation of less than 92% needs an arterial blood gas. So we'll get a PaO2 of less than 8 kilopascals, and the ABG will show you what looks like a normal PaCO2, that is between 4 and 6 kilopascals. This patient will also be exhausted, may have arrhythmias, may have hypotension. So the way I remember it is the patient is breathing fast, he's probably getting exhausted, his heart is probably not able to catch up with it, so he might have arrhythmias. A patient with arrhythmias is likely to have hypotension. A patient who has hypotension cannot oxygenate the tissues well, peripheral tissues well, so will have cyanosis. This patient will, if he's bad enough and his airway is narrowed enough, then he'll have a silent chest. And eventually, this patient will get tired of this increased respiratory effort and he'll have a poor respiratory effort. He'll be exhausted. And finally, near fatal asthma. So, in life threatening asthma, the PaCO2 was normal. The difference between life threatening and near fatal asthma is that in near fatal asthma, there is a type 2 respiratory failure with an increased PaCO2, and or this patient usually requires ventilation with increased inflation pressures. Uh, all patients with asthma are that have a saturation of less than 92% usually should be started on oxygen therapy. In critically ill patients, you're going to give controlled high flow oxygen with a mask that is connected to a reservoir. In patients that are not so sick, we will give high flow oxygen through a regular mask to maintain a saturation between 94 and 98%. But we're not going to wait to know the saturation to start oxygen therapy. However, we're going to try and get the saturation monitor on the patient as soon as it's possible to do that. So, in patients who have a moderately severe asthma or a severe acute asthma, we're going to go ahead and start the patient with inhaled short acting beta agonists. That's salbutamol. So, 4 puffs of a short acting beta agonist to start with, followed by 2 puffs every 2 minutes, which can be continued up to 10 puffs And this whole cycle can be repeated every 10 to 15 minutes if necessary. If there is a poor response to the initial inhaled short-acting beta agonist, then we will give the patient nebulized salbutamol, about 5 milligrams every 15 to 20 minutes, that is driven by oxygen. If this patient shows still a poor response, then we'll give the nebulization through an appropriate nebulizer and give continuous nebulization. If the patient has severe acute asthma or life-threatening asthma, then we will start the patient on ipratropium bromide 0.5 milligrams that can be added to the short-acting beta nebulization every 40 to 60 minutes. This can also be added if there is a moderately severe asthma that is not responding to your inhaled short-acting beta agonist, that is not responding to your nebulized salbutamol. You start the nebulization, the continuous nebulization, and you add the ipratropium bromide as well as IV magnesium sulfate 1.2 to 2 grams over 20 minutes. So all patients with a moderately severe asthma get initially inhaled short-acting beta agonists. All patients with severe acute asthma get initially inhaled short-acting beta agonists. All patients with severe acute asthma that are not responding or they show a poor initial response to the inhaled short-acting beta agonists should be started on a nebulized salbutamol. And if the nebulized salbutamol is not working, you start them on, that is the intermittent nebulized salbutamol is not working, every 15 to 20 minutes. Then you start them on a continuous nebulization. Also, all patients with severe acute asthma and with life-threatening asthma, and all patients who are showing a poor initial response to the inhaled or nebulized salbutamol should be started on ipratropium bromide 0.5 milligrams added to the short-acting beta agonist nebulization and repeated every 40 to 60 minutes. And an IV magnesium sulfate infusion of 1.2 to 2 grams should be administered over 20 minutes. Usually, IV salbutamol is reserved for patients in whom nebulizations cannot be given, and all patients with an acute exacerbation of asthma should be given corticosteroids. So you will give about 40 to 50 milligrams of prednisolone per day for at least 5 days or until recovery, or you can give an IV hydrocortisone 100 milligrams every 6 hours. All patients with near-fatal asthma usually require intubation, that is management by definitive airway and ventilation, and these patients will obviously be referred to intensive care specialists. In addition to this, there are a whole bunch of reasons why you should refer a patient to intensive care, and these are, like I said, if the patient is ventilated, if the patient is showing a progressively worsening peak expiratory flow rate, if the hypoxia is not improving, if the patient is hypocapnic and as a result has a low pH or elevated hydrogen ions, has developed metabolic acidosis, and is the patient is confused, drowsy, or has an altered mental status, or has a poor respiratory effort, is exhausted, and finally, if the patient has had an episode of respiratory arrest in your ER, hopefully you can prevent that from happening and catch the asthma, the near-fatal asthma early. If you have a patient with near-fatal asthma, you should not try and delay the intubation and go ahead and intubate the patient and refer the patient to intensive care. A patient with moderately severe asthma that has improved with your initial treatment, or a patient with severe acute asthma that has improved, you're going to check the peak expiratory flow rate at 1 hour after admission into your ER. And if the peak expiratory flow rate is greater than 75%, you're going to go ahead and discharge the patient. All patients who have been discharged for after treatment for acute exacerbation of asthma should follow up with the GP within 24 hours of discharge. Any patient with severe acute asthma that has persistent symptoms should be admitted. Any patient with life-threatening asthma should be admitted, and any patient with near-fatal asthma, you're obviously going to admit, and you're going to admit in an intensive care unit. Like I said, all patients follow up with a GP within 24 hours after discharge. A patient with severe acute asthma should follow up. A patient with life-threatening asthma should follow up with a respiratory specialist for at least a year. And all patients who have been discharged after a near-fatal exacerbation of asthma should be under specialist care indefinitely. So that's the NICE 2019 guidelines for acute asthma. Just a correction here, in the list of situations in which you have to refer to the intensive care, there will be a decrease in pH because of a possible respiratory acidosis, that is an elevated PaCO2, or just an increase in the hydrogen ions. That's not metabolic acidosis, as I mentioned earlier. So just a decrease in pH or an increase in hydrogen ions, along with any of the other symptoms or signs, should push you to refer the patient to an intensive care unit. So that's essentially the flowchart, and thank you. Hope this helps.